Lerakis,
Ευχαριστώ πολύ, Γρηγόρη. Professor Pavlides, Professor Kofidis, it's an honor, and Professor Iakovou, it's an honor to be part of this great conference. And in the next few minutes, I will try to show you, to talk to you about imaging, mostly, of course, for the mitral valve, is the topic today. And we have many imaging modalities. Echo, of course, is the most important for diagnosis and the planning of the procedure. CMR is important for the gold standard for measuring volumes. And of course, today, CT for planning is very critical. And CT in the last few years, because of the advanced techniques that offers, it's the most critical for planning of basically all the structural interventions. So echo, as I told you, is especially for the mitral valve, is very important to separate and distinguish if it's a primary versus functional MR, the severity of the disease, and of course to plan the procedure. And I know we talk, a lot about mitral valve because, as we know, and especially the surgeons know, the valve is very complex. So it's very complex and difficult to find the device. And that's why we have a lot of devices developing almost every day that try to treat mitral valve disease with transcatheter therapies. Because the mitral valve is a very complex structure that not only includes the valve itself, but also the muscle, the LV, which is very important to take into account when you treat mitral valve disease. And as I tell to our fellows, there is no way to do a mitral valve transcatheter therapy without to be able to cross the septum and the intra-atrial septum, and today we are lucky to have advanced techniques with echo, and especially the 3D and the X-plane, as you can see here, where you can see the intra-atrial septum and decide, especially for each procedure, like the mitral clip procedure, the height and all the things that you have to take care in order to be able to do the procedure safely and effectively. And as you can see here, I'm moving. This is the superior vena cava for the fellows, the inferior vena cava. This is the bicaval view. Basically, to treat mitral valve, you need two views by echo. Bicaval view, which is this view, in order to do the transeptal puncture, and the other image that I will show you, which is the bicommissural view, in order to perform the procedure, the transcatheter procedure. So this is the superior vena cava, inferior vena cava, and on the 90 degrees image, this is the aorta, so this is the anterior part of the septum, and this is the posterior part of the septum. So very important to know these landmarks in order to prevent of having a problem when you try to cross over and cause perforation of the wall or the aorta. So this is very critical. And of course, always the imagers, sometimes the interventional cardiologists and the surgeons don't appreciate very much, but imaging is very critical for, especially for the mitral valve and tricuspid valve, which is not the talk of today. But as you can see, always we are the eyes of the procedure. As you can see, this patient developed a clot, a thrombus on the catheter, on the transeptal catheter, and of course you have to detect this, tell the interventional cardiologist in order to exchange the catheter and prevent of going to the left side with the thrombus and cause a stroke to the patient. So we'll talk today, part of my talk will be the mitral clip, the mitral transcatheter edge-to-edge repair. And as we know, this procedure for a primary MR is, of course, the therapy is surgery, but for high or prohibitive surgical risk with favorable anatomy, it's a 2A indication by the American guidelines and 2B by the European guidelines. And of course, for patients with secondary MR who meet the COAPT criteria, it's for both the European and the American guidelines 2A indication to perform this procedure. So this is a case of a primary mitral regurgitation on a patient with FLEL posterior leaflet. As you can see, the calcium under the leaflet. This was a high-risk patient, wide open mitral regurgitation, and the important things that we take into account when we do this procedure is to measure the length of the leaflets in order to decide if we use which clip we use. You need to have even for the smaller clip, at least 7 millimeters of leaflet. Most of the time, the problem is the posterior leaflet, but you need at least 7 millimeters for the smaller clip and 9 millimeters for the posterior clip. That will make it possible to prevent dislodgement of the device. And also, I should make the point that you have to take into account the healthy part of the leaflet. Any calcium on the leaflet is an unhealthy part. You don't take into account for the measurement because, as you know, if you put a clip on the calcium, there's a risk of dislodgement. And the other thing we do is we measure. Today we have with MPRs on the 3D imaging, we have ways to measure the mitral valve area. And you want to make sure that by putting a clip, you will not develop mitral stenosis. Try to treat the MR with mitral stenosis. And what is suggested is for the mitral valve area to be more than 4, preferably more than 4.5 centimeters square in order to put a clip and don't have a mitral stenosis. Also, another important thing is to measure the gradient through the mitral valve. And because you have to know where you start, sometimes the gradient in the beginning, you should know that may be high because of the high flow from the mitral regurgitation. So everything has to be taken into account. This is a secondary mitral regurgitation. And again, as I tell people, when we did in my previous job in Emory, the first mitral clip took us 5 hours with Pierre Bloch, the interventional cardiologist. It took us 5 hours because we had only 2D, no 3D. Today we are blessed to have 3D imaging. As you can see here, this is the X-plane, and you go across the mitral apparatus. This is the bicommissural view. As I told you, 2 views, bicaval view for the transeptal puncture, bicommissural view for the mitral clip or any other transcatheter intervention on the mitral valve. And here you have the lateral part, which is with the left lateral appendage, and this is the medial part of the mitral apparatus with the aortic valve, the anterior leaflet, the anterior part of the mitral apparatus, and the across is the posterior mitral apparatus. So you have the whole mitral apparatus in front of your eyes. You change the X-plane from one side to another in order to determine where the mitral regurgitation is coming from. And sometimes you have more than one jet, so you have to find all these jets. And at that time, and the place where the jet is, you go and measure the length of the leaflets and to make sure that you have enough length of healthy leaflet in order to do the mitral clip or Pascal device. We use here, we are mostly a mitral clip device. Other places use Pascal. We have used few Pascal devices here, but we are primarily a mitral clip site. As you can see again here, you are now another case. You are in the lateral part, as I told you. You are close to the left lateral appendage, and you have the jet of the mitral regurgitation. You freeze, and you see that the posterior leaflet here, you measure it, is almost is like 9 millimeters. So that's just to give you the what we do and how we do it here for planning, but also during the procedure. And of course, today, again, we are blessed by having great technology. This is Zoom, 3D live Zoom. This is what the surgeon sees when he opens the atrium, and you have the aorta on the top, 12 o'clock, and you have on your left, the left lateral appendage. This is the lateral part of the apparatus, as I told you. The opposite is the medial part. From the lateral part, you have the anterior leaflet, A1 scallop, P1, A2, P2 in the middle, and A3, P3 on the medial. And you see this valve is wide open, secondary mitral regurgitation. This jet is wide, and you know that you will use more than one clip in order to take care of this. Another thing that we take into account is we see the pulmonary veins, because always you have to see to get more objective evidence before the procedure, but also after the procedure. This is the left upper pulmonary vein, and this you can see the flow is normal. This is the systolic, this is diastolic, this is the A wave, but also you have to see all the pulmonary veins. This is the right upper pulmonary vein. From the bicaval view, you clack a little bit the probe and you bring in the right upper pulmonary vein. And as you can see, you have systolic reversal, which signifies severe mitral regurgitation. And this is the diastolic, and this is the A wave. And you want to compare this with after the clip or after the procedure that you do to get more objective evidence that you have a successful procedure. Another technique that another modality we use is the fusion imaging. We have this available in our cath lab. Of course, the surgeons and the interventional cardiologists, they are not very patient using this modality, but we have it, and it's very helpful, especially for the transeptal puncture. And as Professor Kofidis said, it's very important to talk the same language. So if you have a way to have the same image what you have on the echo screen on the fluoro, you can make it easy. The communication is very critical for this procedure. So having this fusion imaging make it easier to communicate between the imagers and the interventional and surgeons who do the procedure. So this is an actual procedure crossing over from the right to the left, as you can see here. This is the guiding catheter. Very important imaging, very important in order to prevent complications. This is the clip, as you can see here. Try to guide the position of the clip, and this is the clip coming into the mitral apparatus in the atrium. Very important technology. I remember this that I thought about this many years when I was in Emory and we're doing this procedure. Today, the clip has an independent grasping ability, which is very critical, especially for difficult anatomies. As you can see here, you make sure that the clip, you should know which is the anterior and which is the posterior gripper. And as you can see here, this is the anterior gripper with the anterior mitral leaflet, and this here in the bottom is the posterior. So you have to know which is what, and having this ability to be able to grasp independently is very, very important and has made this procedure much, much easier. Then you have to make sure that the clip is perpendicular to the commissure of the mitral valve. Very important step, because if this is not perpendicular but oblique, and you try to grasp that way, first of all, you have a difficult grasp, and second, you may disturb the anatomy of the mitral apparatus, and actually sometimes cause more mitral regurgitation than what you start. So very important steps each way, and this is still being on the atrial level before you go down into the ventricle, and you want to make sure that you are on the clip. Now the clip is into the ventricle, and again the same thing, because sometimes if you have a lot of cords, the clip can change position by going from the atrial level to the mitral level to the ventricular position. So we check always again with 3D imaging to make sure that it maintains its position. And here you have to decrease the 3D gain in order to see the clip into the ventricle and to make sure that the position remains perpendicular. Otherwise, you have to clock or counter-clock, depends on the position, to bring it again perpendicular to the mitral apparatus. Then you open the clip. These are, of course, easy steps. And as you can see here, you have the leaflets onto the clip, and you get the feeling that in this case, the posterior leaflet will be a little bit problematic to grasp it. And by having this independent grasping ability, you can grasp the anterior and then move it to posterior, scoop it under the leaflet, and then grasp the posterior leaflet as well. And I hope these things play here. Okay, so this is, sorry for that. Let's see if bring this up. Yeah, I don't know. Sorry for this. Anyway, so this is, in this case, we use two clips. And as you can see, this is the delivery device, very dangerous, actually. And I don't know why the company has it like this. And very important to guide it and come out of the left atrium into the right atrium, and then out of the guiding catheter. Of course, we measure the gradients, as you know, and we don't want to have a gradient more than 4 to 5 at most. And we know the difference that doesn't play too much role for the functional MR, and that's because most of the time the orifice of the mitral valve in the functional MR is large. It plays more role if it's more than 5 in the degenerative MR. But by knowing where you start, and also by knowing the valve area, also that can help prevent basically having mitral stenosis instead of mitral regurgitation. And of course, as I told you before, we evaluate to get more objective evidence the pulmonary veins. As you can see here, with normalized flow. After the 2 clips in this patient, as you remember, the right upper pulmonary vein, there was a reversal, and now the flow is normal. So this tells you that you are not like hallucinating by don't see much MR, but the procedure was successful, and hopefully the patient will feel better. This is a FLEL posterior leaflet with severe mitral regurgitation, primary MR, and this is how the very easy today. In the past, with 2D, you know, we try to see you are what angle you are, to see if you are in A2 scallop, A3 scallop, P1, P2, 3D live 3D imaging, and you can see the FLEL P2 scallop on this anatomy. And this is after, this was a Barlow's mitral valve, and after 2 clips, as you can see, minimal mitral regurgitation. And here by the fusion imaging, there is no color. So moving on to transcatheter mitral valve replacement. Do I have a little bit time, Professor Pavlides?
Yes, please go ahead. We still have.
So as you can see here, many devices, and when you see many devices, you know already that there is difficulty in trying to treat this disease. And I have been part of many of these devices, especially when I was in my time in Emory. But again, for the fellows, 2 views by cable view for the transeptal puncture, because you have to be able to go to the left side unless you do the transapical approach, and I will show you a case of that. And also the bicommissural view, which you need regardless what you do, a transapical or a transeptal, you need the bicommissural view in order to deploy the valve. And the complexity is because of the saddle shape and anatomy of the mitral annulus. To anchor and seal of the valve in a higher pressure environment of the LV, the proximity to the left circumflex coronary artery, and the most important problem that we have is the risk of LVOT obstruction. I think that's actually the biggest problem we have to try to treat this with devices. We are here part of the Apollo trial, and I love this image. There are 2 or 3 transeptal at this time valves for this of this type, and this is again transeptal therapy. Again, as I told you, by commissural view. This is again the left lateral appendage, lateral part of the apparatus, the medial part of the apparatus, aortic valve, anterior, posterior, severe mitral regurgitation on this patient, high risk, CT critical. And we have, of course, today with 3D technology, echo, we can measure the annulus. We do this all the time in order to compare the techniques, but CT is very critical to measure the area of the annulus and decide of what size of valve it will be used. But most important, as I told you, the most critical difficult aspect of finding and treating mitral valve disease is the development of LVOT obstruction, which, if it happens, is catastrophic. So as you can see here, CT is very important. By using a simulator and putting the valve that you plan to put on the patient, to place on the patient, and measure, as you can see here, what we call neo-LVOT, to see if the risk of obstruction is high. And of course, the companies today actually, for this trial, they move the target always to a larger neo-LVOT. So this, at least for Mount Sinai, this is, and we have Dr. Adams, who is the PI of the trial, of this trial. This is the biggest problem for us in recruiting patients, the risk of neo-LVOT obstruction. And CT is very critical. As you can see in this particular case, the neo-LVOT is 525 millimeters, and usually it has to be above 200, 220. As I told you, it's a little bit a target, moving target, started from 180, but now it's about 220. And also the aortomitral cortin, aortomitral angle, very important, which is basically measuring the angle between the annulus of the aortic valve and the annulus of the mitral valve. And as you can imagine, the wider it is, the less the risk of having an obstruction. The highest risk will be if it's perpendicular, where you will obstruct completely the LVOT. So these are very important measurements, and all this always a big discussion between the surgeons, the interventional cardiologists, and of course, if you have a neo LVOT of 525, there is no discussion about it. The problem is if the neo LVOT that you get from CT, it's close to the margins of what is acceptable and what is not. And this is again very the same transeptal. You have to go to the left side, as I told you, by caval view, superior vena cava, superior part of the septum, inferior part, anterior with the aortic valve posterior, and this is a safe cross catheter that we use sometimes to cross over to the left. Now they cross already to the left. You have to dilate because of the how big is the catheter. You have to dilate the septum in order to be able to cross over. As you can see here, the balloon and this is the valve as you see here. Just for the interest of time, deployment is, as you can see, the valve was deployed. Everything looks good. As you can see here on 3D, from severe mitral regurgitation, no MR, no paravalvular leak in this case. And also, in order to prove that the CT was correct, you measure the gradient through the LVOT, and as you can see here, the gradient is a peak gradient of 7. So everything went great on this patient, and we knew that that would happen because of the ankle of the and also because of the measurement by CT. And I know that now for 10 times this has got approval in transapical has got approval for Europe, and this is a case from Emory. We did many of these cases many years back in Emory, and again, you need CT in order to determine the path that the catheter has to take through the left apex. And as you can see here, this is actually the surgeon, as you can see, who with his finger is pointing into this was Dr. Guyton in Emory, pointing to where you have to, the catheter has to cross from the apex, and it's a straight shot. Actually, very easy procedure if you do it. If you compare transapical mitral valve replacement to transeptal, transapical is much easier, but of course we know the problems by giving another injury to the ventricle of these patients. So that's the problem, and that's why I think the long-term therapy, transcatheter-wise, will be transeptal mitral valve replacement. And this is how the valve looks before it's deployed, and this is after deployment of Tentyne valve. Last but not least, cardiologists are very smart people and always develop techniques. This is a patient, as you can see here, with mitral prosthesis, bioprosthesis, stenotic, very stenotic, doesn't open, as you can see. And you can see here, high risk patient, very high risk. The transcatheter therapies were considered basically to do valve-in-valve therapy in this particular case. But as you can see here, you can tell that the LVOT, you don't have to do CT. You can tell that the LVOT here is very narrow. And you can tell that most likely if you deliver a valve there, you may end up obstructing the LVOT and cause a catastrophe. And this patient, as I told you, had a CT, and any neo LVOT predicted 81 millimeters square, very, very small to try to do this procedure. But as I told you, cardiologists have a lot of discoveries. This is a Laboon procedure, left laceration of the anterior mitral leaflet to prevent LVOT obstruction. I would like to do the first of this again in Emory to image the first procedure of this in Emory. As you can see here, very easy today with the 3D to find the leaflet that corresponds to the anterior part of the mitral prosthesis, and this was not the one. As you can see here, this was the anterior leaflet of the prosthesis that you basically try to cause laceration, to cause a hole, and then you put the valve-in-valve, and by having this opening of the leaflet, you prevent obstruction of the LVOT, and this is what happened here. As you can see, it's complex procedure, but now it's much easier. Many centers do that. As you can see, the anterior leaflet of the prosthesis is completely lacerated. As you can see here, the flow through the laceration of the anterior leaflet. And now is under rapid pacing, is putting the new valve, 26 millimeter Sapien Resilia valve. As you can see here, from severe mitral stenosis, post-valve in valve, wide open and not new LVOT obstruction. As you can see here, flow through the LVOT. This procedure would not have been able to be done without to have the Laboon procedure, or if you have done without Laboon, it would have been a catastrophe, complete obstruction of the new LVOT. So thank you very much for your attention. And again, as I told you, this is my last slide. Many people involved for all these procedures, from the surgeons, the interventional cardiologists, the imagers, the anesthesiologists, but also our nurses. And here we have also nurse practitioners, coordinators, very critical for the success of any transcatheter valve program. And I will be happy to answer any questions. And again, it was a privilege to be a part of this meeting and be able to give a talk in Onassis heart meeting. Thank you very much.
Thank you very much, Samati. This was an excellent review. Any comments, others?
Well, Professor Lerakis, you certainly bring the imaging and decision-making, or if you wish, personalization of treatment to the next level with the methods you have up in your sleeve. So let me push it up one notch and ask you a question, as well as make a proposal and invite you here and now out of this podium for a collaboration. So I had started a project in Singapore, and after my return to Greece, of course, it had to be interrupted, but now I'm preparing the application for this again, for some European funds. Now, you'd be surprised to know that we heart surgeons, as much as our instruments and tools have evolved, we still, in my view, make primitive decisions. Don't be shocked. What I mean is that imagine we open up the left atrium to replace the mitral valve, right? So our decision is two-dimensional. We use a primitive plastic tool to measure the dimensions, the void that is left behind after we remove the heart valve. Now, the heart is stopped in an end diastolic position with the cardioplegia. But we don't take into consideration so many other aspects of the system of the mitral valve, the heart, and the patient around it. That means if we have a 25-year-old patient with a measured size in cardioplegic arrest of 30 millimeters, we will ask the nurse, unpack a 30-millimeter heart valve. That's all. If we have a 70-year-old patient with half the ejection fraction, and we measure 30 millimeters with this primitive tool, we will still ask the nurse to unpack a 30-millimeter valve. So the valves that we have in our armamentarium are also primitive circular devices that allow for unidirectional flow, just like 70 years ago. 50 years ago in our profession, more or less, with small changes. So what I'm trying to say here is that back in Singapore, I tried to look at functional criteria to make better predictions and personalize the treatment. We don't look at the ejection fraction. We don't look at the LVEDD. We don't look at the global longitudinal strain of the left ventricle. I would like to have your comment on this. I mean, you have access to a massive database at ICANN, Mount Sinai, because I envision that AI will be the next generation as a new algorithm and protocol to guide our decisions in choosing the right treatment or the right valve for the mitral valve. And we'd hope to have your extramural co-investigatorship and collaboration on that. What's your thought on AI as a powerful tool in taking into consideration all dimensions of mitral valve disease.
Yes, thank you, Professor Kofidis, and I have followed your work, and I believe strongly on personalized, medicine, and of course therapies. And I know your great work that you have done in Singapore, and I followed very closely. But I agree, and actually yesterday we sent out a paper using AI. We have a fantastic AI program here in Mount Sinai. We actually yesterday submitted a paper using AI for aortic valve, for TAVI, which valve, which platform, which size, and all this stuff. So I agree, with AI today, we are getting in different levels of abilities, and I agree with you that, as you say, putting the same valve on somebody 70-year-old versus 25 with low EF, we have so much technology today. We can measure basically everything, and we do measure everything, but I think we have to put it to work, and with machine learning and all this technology, I think, the future is bright. We just have to use it correctly, because even AI sometimes, as you know, may give us false information. But I'm with you, and I'll be, of course, happy to collaborate. You have huge databases here, and with your databases in Singapore, in Greece, we can achieve a lot with your expertise. And I'm for it, and I will be happy to help in any way. But AI is, we do AI for everything. From EKG, from MECO, from, as I told you, we just sent a paper yesterday about TAVI, and I'm sure mitral clip, all this mitral valve replacement, all these things are on the works, and pretty soon we'll have solutions. I don't know if we'll be able to solve all the problems, but for sure we can do better compared with what we do now.
If I can add something, is that AI, as we use it today, we need a big database for the machine learning technique. And I think that Mount Sinai, having the mitral valve program for many, many years, probably has a huge amount of data that could do that. So you have to feed the system with all the data, and then it will give you the answer that Dr. Kofidis just said. So yeah, that's probably the next step.
I call upon all cardiologists involved here, and of course, Professor Lerakis. I totally agree with Professor Pavlides, because it's a matter of calibration of the algorithm. And that's the volume and the thousands of cases we need to calibrate before and after surgery using those parameters, functional parameters, will be thousands. And therefore, we hope that we'll have Professor Lerakis' help moving forward.
Any final
I would be very happy, Professor Kofidis is very happy to collaborate and do whatever I can from my part and from Mount Sinai. It would be a privilege.
Yannis?
No, Stamati, this is an excellent presentation. Thank you for that, and thank you for sharing all the insights about the use of AI in how to better, implement these technologies in the everyday practice. So thank you for that, and hopefully we'll see each other very soon and have you here.
Thank you, Yannis. Always great to see you all, guys. Always great to see you. Pleasure. Yes.
Yeah. Thanks.
Thank you, Stamati, again. Thank you.
Thank you. Καλή συνέχεια. Ευχαριστώ πολύ.
Ευχαριστούμε.